the interface between the axial skeleton through the spine and the lower extremity is the pelvis. And we've spent some time in the spine. We appreciate the fact that gravity influences the large bulk of the body inferiorly. So the spinal interface through the sacrum with the iliacus, the SI joint, you know a great deal about, disruptions here through subtle malalignments can really be problematic for your clients. And likewise, the force moving from, we call it ground reaction force, up the kinetic chain into the hip, then the pelvis serves as a universal joint to transmit that force up the kinetic chain. So this is the interface between the axial skeleton and the appendicular skeleton. In the fetus, when you were in your mom's uterus, these three pelvic bones were actually three separate bones, so they're called the innominates. So the iliacus, the pubis, and the ischium converged, they fused, and their articulation directly is through the pubic symphysis, which is an amphiarthrosis joint, because there is a disc. When great force is applied, there can be dislocation here with major ramifications for bowel and for nerve. And then we move into what I ask you to focus on for next time about the musculature of this joint, the hip. Obviously a diarthroidal joint with 3 degrees of movement, a great range of motion, so great range of motion emphasis, therefore there's challenges to stability. And so there are major ligamentous complex to hold that together. I'm going to come back to the relationship of pelvic movement to spinal movement. When the pelvis rotates posteriorly, the spine goes into flexion. When it rotates anteriorly, the pelvis goes into extension. When we laterally flex, or when we tip our pelvis to the left, our spine laterally flexes to the right. That's to keep us upright. So if we drop our hip here, then we can't compensate to get our center of mass over our base of support. So I want you to appreciate pelvic movement. We move just right now into the femur. You appreciate that the head of the femur fits into the acetabulum, the neck of the femur, which is very vulnerable in elderly people. Osteoporosis very often is manifested here, very frequent site of fracture in older people. The greater trochanter, the lesser trochanter. Lesser trochanter, I'm going to talk to you about the 2 muscles that attach there, psoas and iliacus, and then gluteus medius and the deep, gluteus medius and minimus, and the 5 deep intrinsics of the hip, major rotators attach on the greater trochanter. And then the distal aspect of the femur. This is posterior view, so condyle with a trochlea between. And anteriorly, I want you to appreciate this tubercle right here. This is the adductor tubercle. When I get a picture here, an illustration of the adductor magnus attaches to the pubic bone, and it sends fingers to the linea aspera, which is the roughened part here, posterior femur, but its last tendinous finger goes way, way down here, and I want you to know how to find that palpation. We've said to you that the hip has how many degrees of freedom? That's right, it's triplanar, so 3 degrees of freedom. And because there's so much movement at the hip, there needs to be major ligamentous support or attachment between the femur and the greater or the pelvis. And this is how you remember this. For each of the 3 pelvic bones, there's a major ligament that passes to it. So there's ischiofemoral ligament called the Y ligament that I messed up. The ischiofemoral ligament is posterior. It's right here. That's posterior. The iliofemoral ligament is the Y ligament. And the pubofemoral ligament obviously is anteriorly situated. Those 3 major ligaments help stabilize the hip. In cross-section, the muscles of the thigh are in 3 major compartments. Now, why do we call them compartments? Because there's deep fascial enveloping around them. And those 3 compartments are the anterior compartment, the posterior compartment, and the medial compartment. You're going to look at the muscles of these in their longitudinal coursing, but it's good to know that these are the component parts, and actually in dissection you have to open these fascial compartments to gain access to the muscles. The clinical implication is if you have a crushing blow to one of the compartments and there is a bleed into the compartment, the pressure can get so great that it exceeds arterial pressure. Muscle tissue and inert tissue does not receive nutrition, and necrosis can occur. That happens more frequently in the compartments of the lower leg, but it can happen here. I asked you Tuesday to know your muscles by neighborhood, and so the anterior muscles, their common action is flexion of the hip. The lateral muscles are abductors, the posterior muscles are extensors, the medial muscles are adductors, and then in combination they work to be rotators. So here are the major flexors. These are muscles that pass anterior to the frontal axis of the hip. The psoas and the iliacus, the one muscle of the quad that passes the hip. The vastes, the 3 vastes, don't come across that axis of rotation at the hip. The only one that does is the rectus femoris. And then the tensor fascia lata and the sartorius are hip flexors as well. The medially situated muscles are adductors. You know the 3 adductor muscles to be brevis, longus, and magnus. The pectineus is superficial to the adductor brevis, and the gracilis also is an adductor. Okay? I mentioned this about the adductor tubercle way here, way here. This is the adductor magnus. Superior attachment of these adductor muscles are on the pubis. The magnus sends fingers of muscle to the linea of aspera, and its very most distal attachment is on this plateau of the femur and of the condyle of the femur, called the adductor tubercle, and I'll show you how to palpate that. And then posteriorly, the extensor muscles, the gluteus max is a major extensor, and then the hamstring, semimembranosus and semitendinosus. These are the major extensors, along with the other hamstring muscle, the biceps fem. The 3 tendons of semitendinosus membranosus and biceps longhead attach on the ischial tuberosity. Short head of the biceps fem is on the posterior surface of the femur at the linea aspera. Their effect, because they're posterior to the frontal axis, is extension. And then the abductors, laterally situated muscles, the 2 smaller gluteal muscles are major abductors, along with the tensor fascia lata. Okay, so when you touch yourself posterior hip, and abduct, posterior lateral hip, you'll feel those muscles become very firm. When you extend your hip, you'll feel the more, just a little bit more inferior, the gluteus maximus. And then internal rotators include these muscles. And rather than read them, well, maybe I need to. So the two smaller gluteus are internal rotators. Now I'm going to talk to you about external rotators in just a second. So the gluteus medius, gluteus minimus are internal rotators, along with the adductor group, the hamstrings, and the gracilis. What I want you to know about the gluteus medius is it's an anatomic analog to our deltoid. The deltoid has three heads, and so it internally rotates and externally rotates, and the gluteus medius does that, but it's primarily an internal rotator, abductor. And then the external rotators are the gluteus maximus and the intrinsics of the hip, the piriformis gemelli, obturator, and the gemelli, there's two of them, and the quadratus femoris. All of them are external rotators. So this is a posterior view. They attach to the pelvis and the sacrum and to the posterior greater trochanter. So when they contract, you can see that femur externally rotating. And then it's just like in the brachial plexus that supplies nerve supply to the upper extremity. There are two plexuses formed by the commingling of nerve roots, the femoral and sacral plexuses, and they form the nerves that supply the lower leg. And just because it's probably easier to express in class, but suffice it to say the femoral plexus supplies the femoral nerve, which supplies the adductors and the anterior thigh, and it stops just superior to the patella. So anterior and medial. The sacral plexus gives rise to the nerve that you hear so much about, the sciatic nerve, which really is two nerves. The sciatic nerve forms the tibial nerve and the peroneal nerve. And I think that'll be it. My word of encouragement to you is be a student of the anatomy, to be ready for Thursday's class. Know the muscles by region and action, and we're underway. I just think we're in for some great times on Thursday. God bless you. Bye.